Thanks for the invitation to presentation today. My name is Jackson. I am a resident of trauma surgery in Unicamp. And we talk about stab welding thoraco-abdominal area. It's a male, 44 years old, and he was a patient was drunk and involved in a bar fight. When in this fight, in his fight, he's wounded by a knife, one in thoraco-abdominal area and other in back. And the time between the injury and the arrival at the hospital was about 3 hours. He was speaking without signs of obstruction, no cervical immobilization, the respiratory rate was 16, and the oxygen saturation was 19.8. They had reduced breathing sounds in right thorax, but don't have had without air escape or bleeding in the wounds. The heart rate was 19, the blood pressure, they have not hypotension, and the warm extremities. The Glasgow Coma scale was 15, and they didn't have another injuries. The abdomen is flaccid and without pain or tenderness in the abdomen. And we can see in this picture the wounds. One in thoraco-abdominal area and other in back. The EFIS of the patient was positive for right hemothorax. And when we did the EFS, the patient did a hypotension. And this is the laboratory test in trauma bay. We can see a base excess almost very negative, almost 8 negative, and lactate about 3.
So just to add some information, this patient, he was at the bar having some beers, and he was very drunk, and there was a fight, and he received 2 stab wounds. He stayed at the bar, and they called the pre-hospital, but he was stable and not afraid about the injury because he was bleeding, little amount of blood in the thoraco-abdominal area. So they called the pre-hospital, and he arrived at our hospital 3 hours after the injury. 3 hours after the injury. It was early in the morning, 6, 7 a.m. This was during a weekday, and he was received. Go to the picture again, so you can see this is the injury. One here and the other. This photo was some minutes after his arrival in the hospital. There was a suture here and the other suture here. This is the axillary area. So the posterior axillary liner is here. So it's the transition of thoraco-abdominal and the transition of the flank, the lateral area of the abdomen, and maybe this in the back, just on the line, axillary posterior line. And he was totally stable when he arrived. And after put the chest tube, there was a hypotension, but was treated with crystalloid. After 1 liter of crystalloid, the patient recovered very well, was totally stable again. And the gas lab, you can see there was a lactate of 3 and base excess minus 7.8. So there's a discussion about if it's necessary to activate the blood for these patients. Not yet, because more than 3 hours after the trauma. And the next step for the patient with a positive FAST on the right chest. And the chest, in the chest drain, did you put the information? 400 milliliters of blood on the chest tube. 400 milliliters of blood. And we ordered CT. Let's discuss about the treatment at this moment. If everybody agree or suggest other treatment to do, if they ask blood for the patient or not yet.
Go to
Doctor, okay,
ahead.
you can moderate. Gary, please moderate, please.
Yes, sir. Dr. Calais?
Yes, this patient is in shock. He has acidosis and he has a big excess, mean or big excess. So I believe this patient is in shock. So in this patient, need to make probably go to after because is young, but maybe presentation maybe needs some blood. The patient has in these situations you have the patients have injuries of the posterior transition of the back, thoraco-abdominal transition on the right side, correct?
Correct. Right size.
Yes,
right,
the right
yes.
side. Yes, it's sometimes you have a problem in these situations because you have in these situations you have a diaphragm and you have the liver. So usually these injuries maybe can be only the chest, but sometimes it comes from the abdomen and have injuries can see the blood comes to the liver to the chest. So in this moment, sometimes you have to investigation where the surrounds of the blood on the chest. Sometimes maybe from the chest only, but in this situation, this position, we can to see this no liver injuries in this position of the patient. So the patients are maybe more stable. I can go to a angio CT to see what's happened. But I think these patients probably need some blood. One thing is important when you have injuries in the situation, you can thinking about auto transfusion. Ou seja, reuse the blood from the chest for the patient. So sometimes in this position, when they have a big hemothorax, maybe you can reuse the blood from the chest. So that's the way I can do in this patient. I think these patients need to be control the hemorrhagic transfusion and may be necessary and go to angio CT.
Thank you, Dr. Calais. Let's go to Panama. Dr. Chiadetis?
Hi, yeah, well, with that blood gas, you can tell that the patient is acidotic. He has a base excess of -7.8, a bicarbonate 17. Those things talks about profound shock. And if you are thinking about blood transfusions or not on this patient, well, he has taking an ABC score, he has a penetrating injury, and he has a positive FAST. So I think he has a lot of possibilities to need some other treatment, especially with blood products, and maybe a massive transfusion protocol. I'm kind of these transient responders with fluids. I think those patients are really sick, and then they can crash even if you take them to the CT. So I will go with this patient to the CT, but I will be there by myself so I can see the images right away and take the decisions that needed to be done right away. So this is not the patient that I just asked for the CT and then go do something else, and I will accompany this patient to the CT.
Thank you, Dr. Chiadetis. Let's go to Portland. Dr. Kasim, your comments, sir. Check your mute button, please. Oh, thank you.
This is a young patient, and he comes to the trauma bay 3 hours after a two-stab wound, and the trajectory is not known, but you know, it is. You should suspect at least 2 cavity injury, one in the chest and possibility of abdominal injury is very real in this particular patient. He is in hemorrhagic shock. So the current ATLS recommends that you don't give more than a liter of fluid, and then you should transition into blood or blood product as soon as possible. I don't think there is an indication for exercising massive blood transfusion protocol at this moment, but at least you should be aware. You should inform the right people that you may need it later on. So once you have, I think I would put a chest tube in on the right side, which you have already done, and you got 400 cc of fluid coming from there. And you've done EFAS, and you have hemopneumothorax, but you should also do an abdominal FAS to see if this abdominal cavity has any blood in it. And while you're doing that, it's a good idea, at least you should practice initially to look at the infravena cava to see what it looks like, so that you get a good idea what the vena cava looks like in a patient who has hemorrhagic shock. And you will get a lot more information as you continue doing that more and more for the future. Regarding sending the patient to the CT scan, and my colleague from Panama is 100% right. This patient can crash in the CT scan, and as Dr. Trunky has told us many times, it is a deathbed if you send the patient to CT scan who is in hemorrhagic shock. So go with the patient like my colleague in Panama would do. I really, really commend her for saying that. So we all should listen to her. You should go with the patient to the trauma to the CT scanner with the patient if you are thinking of doing that. But I think abdominal FAS is very helpful as well, and looking at the vena cava is going to be very helpful. And giving the blood, giving blood transfusion is going to buy you time so that you can get a CT of the abdomen, so that you can plan what you're going to do next to this patient. Thank you.
Thank you, Dr.
Just-
C. Go
Just
ahead.
information. Gary?
Yes, sir, please. Go ahead.
Just information. The FAST in the abdomen was negative. No blood in the abdomen. Only on the chest on the right, there was blood. And after give crystalloid, the patient, he received a total of 1 liter of crystalloid. The blood pressure was 120 after crystalloid, 110 plus 60. And the heart rate was 86. So the patient after crystalloid was better. And you have the decision to go to the CT. But let's send the opinion of the others
Okay.
place, other hospitals. Thank you.
Yes, sir. Very well. Dr. Calderon in Lima, Peru.
Yes, this patient initially stable 3 hours after the stabbing wound. As he becomes hypotensive, that responded to initial crystalloids, but I must think that he's bleeding somewhere. Maybe the chest, that where the chest tube through about 400 milliliters of blood, but he can also have some bleeding source in the abdomen, could be in the liver or even in the kidney. So I would it's okay. I would place the chest tube, what's already placed. I would look carefully the output, what would come out after those initial 400. I would transfuse a couple of packed red blood cells. As Dr. Kasim says, it will buy us time. I would not activate the massive transfusion protocol yet, but I must be ready in case of the patient's crashes or becomes hypotensive again. Not only ready to activate the massive transfusion protocol, but also to be ready to take the patient to the operating room if he becomes unstable, right? So, but now that the patient has become stable, he received almost a liter of fluids in your hospital, but have in mind something that he already received extra fluids from the outside hospital, another 2 or 3, 1 or 2 liters. So I would take the patient, if the patient is still stable, I will take him to the CT scan. But I must say, in my hospital, at least, we have the CT scan suite is very close to the emergency department. That's another thing to have in mind. The CT scan must be close enough to your ER and on the way to the operating room in case that we have to take the patient quickly. But yes, so far that's all I would do. Check the output from the chest tube. Be ready for more transfusion and take some images to just to make sure there is no intra-abdominal injuries. Thank you. That's it.
Thank you, Dr. Calderon. In Atlanta, Dr. Frisbee, thank you for your patience. Your comments, please.
Appreciate all the comments. You know, Calderon's right. You better be pretty close to the ER if you're going to take somebody to CT. Feliciano used to tell us, "Oh God, I don't want to do this." You know, especially in a really early responder. He's been stabbed in the place. You know, that's just if he didn't get the liver, I would really be surprised. At this point, you know, you're at your limit for crystalloid. I would give him some colloid, give him some blood. I agree. I don't think it probably is time for the massive transfusion protocol, but I'd be ready, and I would definitely go with him to the CT because this is the guy who's going to crash on you. We've seen this more than I can tell. They just look too good. He's probably a strapping young guy, you know, but the hubris of the young, he just doesn't want to come and to tell anybody he's injured. And by that time, he's out of steam. So he's going to run out of steam on you. And if you're in a place like a CAT scanner, you're in a bad place. But I agree with all the comments. I think we're going in the right direction here. That's all I've got.
Thank you, Dr. Frisbee. Dr. Moscoso, your comments, please.
Yes, I will proceed with the CT. And probably get ready a couple of units of package of blood. Because in my hospital, it takes a lot of time to get to the ER.
Thank you for your comments, sir. Do we have any additional comments before we return to Campinas, to our presenters? Okay, back to you, Dr. Bertuol, Dr. Fraga.
Now we share the CT.
We just lost your presentation, sir. Okay. Okay.
Good morning. My name is Laís, and I will present the images of this case. So we can see here in the non-enhanced phase, the hemothorax with the chest tube. And we can see the retroperitoneal hematoma in the right flank. Here we can see the retroperitoneal hematoma and the track of the injury. Here is the arterial and portal phase, and we can see the liver and the kidney laceration, and the the counter abnormality of the inferior vena cava. Here we can see here, just a minute. Here the kidney laceration, the liver laceration, and here we can see in the cava, the contorno injury here. We can see better here. So in the, I selected these images, we can see the track of the injury here, with the laceration in the kidney in the liver. And here the subcutaneous gas. And here in the cava, we can see this hematoma. And this image that can be in flap, we don't know. But anyway, we can show, this patient show one finding of primary IVC injury, that is the contour abnormality of the parietal, and secondary findings, including the retroperitoneal hematoma here, and the hepatic laceration. And these are all the images of this case. Most important, there is the kidney and liver laceration, the retroperitoneal hematoma, and this abnormality of the cava. So this is the images of the case.
So there was a lot of discussion here when this patient arrived, and we discussed with with Dr. Laisi, the other very experienced radiologists, because he observed one stab wound with the liver and the kidney injury, grade 2 each one, and the other stab wounds with a large retroperitoneal hematoma, and probably with a cava vein, inferior cava vein injury, very small, because in the wall of the cava vein, there was something wrong, suspicion, high suspicion of the cava vein injury. The patient has obesity, a little fat, the patient, and he was totally stable after the CT. So the discussion was just to observe, go to the ICU as a non-operative treatment, because we were very comfortable to treat the liver and the kidney non-operatively. And how about the cava vein? Is possible to perform a non-operative treatment in the cava vein? So this is a good question for our panelists. Go ahead, Gary, please.
Yes, sir. Atlanta, Dr. Frisbee, your comments, please.
I think he's going to the OR. He's walking to the OR.
Yeah. You know, one of those 2 stab wounds has done what Maddox used to say, is hit the
Dr. Frisbee,
really sick.
Dr. Frisbee, you can move close to your access point, or you can try to block your video so you can conserve your bandwidth so we can hear you.
All right.
Just go ahead and try to block your video. We should be able to hear you clearly where you're comfortable then.
I wouldn't even know how to start blocking my video.
It's right there next to your mute button. There you go.
Can you hear me now?
Yes, sir. We should be fine and you should be comfortable. Win-win. Thank you, sir.
Yeah. You know, as I said before, Maddox used to call the right upper quadrant the worst place in the world to get injured, because you've got the liver, you've got the kidney, you've got the hepatic flexure, and you've got the vena cava. Well, this guy's batting 3 out of 4. I don't know which one of the stab wounds did it. Apparently, it doesn't really matter at this point. But I still believe he's got some type of issue with his diaphragm. You found all that blood in his chest tube, so he's probably got a violation across the diaphragm also. Your question had to be, what can we do about the vena cava? And that's, I think that's the question of the moment here. I would probably do a venogram, see how much injury you've got there. This is a very vital structure, and if you leave it to chance, gamblers never win. So I would go ahead and get a venogram, but that's about all I've got.
Okay. Thank you very much, Dr. Frisbee. Portland, Dr. Kasim, your comment, sir. You're muted, Dr. Kasim.
I totally agree with Dr. Frisbee. The $64 question at this moment is, what type of damage did he do to the IVC? But along with that, he also has a hole in the diaphragm. That the knife must have gone through the diaphragm into the liver, into the kidney, and then nicked the IVC. The liver injury can be treated conservatively, NOM, and the kidney injury is NOM. Comes down to the IVC, and of course the diaphragm has to be repaired, not immediately because it's a right-sided injury, but sometime along the line you'll have to repair that too. To get a better picture of the IVC injury, one can do a venogram, and to see if the IVC injury is just a little nick, and or has it done damage to the part of the circumference of the IVC to a degree that you may not be comfortable going to sleep over it, and then you may want to think about doing some type of repair. And at the same time, you can also repair the diaphragm. So IVC will be a good start, but you should keep this man under tight control because the dam could break any time. Make sure that you have plenty of blood in the bank available for immediate use. Thank you.
Thank you, Dr. Kasim. Lima, Peru, Dr. Calderon, your comment, sir.
Thank you. Yes, of course, the blood bank and the ICU must be ready for this gentleman. Well, my comments about the case. First, about the imagings, I have to say that the chest tube is in well position. You have to check that. And the hemothorax is well drained. Now, in the abdomen, he has the liver injury, the kidney injury, the vena cava injury. The question is, where does the retroperitoneal hematoma come from? Is it from the kidney? Is it from the vena cava? It's likely from the vena cava. So what to do about it? It depends on how stable is the patient and what are our available resources. Yeah. Well, I'm concerned about a possible diaphragmatic injury, but I would like to know first, what about the bleeding? Well, if we have a vascular surgeon or interventional radiologist who could make the venogram and possibly do an endovascular treatment, I think I would take that option first, just to make sure that if he can repair the vena cava by an endovascular method. But that's not a possibility in my hospital and in many places, especially in which hour of the time it is. Maybe we have, maybe we have to take the patient to the OR, just to first to take a look at the vena cava, to take a look at the kidney injury, to take a look at the liver injury, and to take a look at the diaphragm. Possibly the kidney and liver injuries are only for conservative management, but with such retroperitoneal hematoma, I must be sure, I must take a look by myself. Yes, thank you. That's all the comments I have by now.
Thank you, Dr. Calderon. Dr. Quiedetis in Panama, your comments, ma'am.
Well, I just want to ask some little question with the CT. Did you did a late or excretion phase because of the ureter in the right side? We have plenty of patients with these types of injuries, and we miss completely during the CT if we have it, or intraoperative if we have also an ureter injury. For me, I feel really uncomfortable trying to manage these patients non-operative. So I will take him directly to the OR, and I will explore the vena cava, and if it's infrarenal, I will just tie that injury or suture, it depends on the hemodynamic status of the patient. And with the ABG that you showed me at the beginning, I think this patient is bleeding a lot. So I won't be comfortable doing non-operative management of this injury. So I will take him directly to the OR.
Thank you, Dr. Quiedetis. Dr. Moscoso, your comments, please.
Yes, considering that in my hospital there is only radiologists from 8 a.m. to 2 p.m., we will probably have to explore the patient. No? It depends basically what with resources you count. We don't have all the time vascular surgeon or the possibility to endovascular proceeds. So for us, it's better to explore the patient.
Thank you, sir. Sao Paulo, Dr. Calais, thank you for your patience, sir.
No problem. It's very nice to listen to others. I think first, the surrounds of the retroperitoneal hematoma may be for several surrounds. One surrounds may be the kidney, the other surrounds may be the liver sometimes, but the muscles, the psoas muscles, and vessels from the retroperitoneal or some arteria or some lumbar veins, and the vena cava. You have upper injuries, maybe probably take the diaphragm, take the liver, and take the kidney. And then inferior injury maybe probably go to through the muscle or iliopsoas muscle or dorsal muscles and into the vena cava. There is no contiguous injuries from the vena cava to the peritoneum. There is no blood in the peritoneal cavity. So it's retroperitoneal injuries of the vena cava only. So sometimes it's tamponated. And if it's tamponated, it can wait. Can usually go to make a venography and see if there is bloody is blending from the vena cava or not. If not, it's tamponate. If you go to OR, sometimes you can, in this situation, you can go and open the retroperitoneal hematoma and can the patient blood too much and very difficult. In some cases, it's very special cases. If you have a tamponate injuries in the retroperitoneal, you can wait and the patient can be not treated for the vena cava injuries at this moment. If you don't have image exam in this patient, in this situation, maybe probably the patients go to OR. You have the exploration of the liver, the kidney, and the vena cava, and the duodenum can be probably in the position of the liver and the kidney. You have injury of the duodenum, although you don't have gas in the retroperitoneal area. So depends on what means you have, what we think about. But I think in this situation, if the patient is stable, I can make at this moment maybe a venography of the vena cava If the injury is tamponated, there is no, I can wait. And later, 1 week probably, go and see the diaphragm if there is injuries to repair, and repeat the veno cava for later time. If you don't have this means and don't have means to observe this patient, I go to OR and try to fix all the injuries. Sometimes some injuries may be treatment only a drain. Sometimes they may be on suture and time in sutures. That's the way that I think about in this case. I have one case, I have injuries of the vena cava with blood from the hepatoperitoneum that I don't know, I don't do suture of the vena cava, and the patients go well. Okay.
Thank you, Dr. Calais. Do we have any other comments before we return to the presentation? Okay, back to you, gentlemen in Campinas.
Well, we didn't do a venography because we think if it is positive, it's not change the treatment. And we did for this patient a non-operative management. And we started a prophylactic heparin and feeding after 14-18 hours. And we did a new CT, control CT on 50 day and removed the chest drain on 50 day. The new CT don't show us another alterations. Is a stable injuries about all the organs. And this patient was discharged after 7 days of hospitalization and was totally stable.
There was so many discussion here when the patient arrived to have this decision to not operate the patient because the patient was stable after the hypotension on admission. The patient was stable, no blood was necessary for this patient. You just put the patient at ICU to have a good control of the hemodynamic status of the patient, and the patient was always stable. We discussed about the venography with the radiologists. So you are planning to have a venography in the other day, but the patient was okay. You canceled the exam because the treatment was will be the same, non-operative treatment. And about the diaphragm injury, we discussed again the image with the radiologist was very posterior in the posterior axillary lining. So the liver is there. Probably was a small diaphragm injury, but it's very difficult to have hernia on the right. And you know there's so many cases of non-operative treatment in gunshot wounds on the right thoraco-abdominal area. So the option was to keep the patient in non-operative treatment. The patient returned 2 weeks ago, one month after the trauma, to the outpatient clinics. He's doing okay, he's going well. Maybe in the future, you can have another CT just to look if something from the abdomen is going to the chest. But I think with the liver will protect, he will not have a diaphragmatic hernia. So let's go to the final comments.
Thank you, sir. Dr. Calderon, and I'm sorry.
Just to Dr. Cassim, I have not slept the last days. The last 40 days, I have not slept for about this case.
Dr. Calderon in Lima, your final comments, please.
Yes, fine. Well, it seems that the patient did it well, and that's fine. I would do the venography just to make sure at least the size of the injury in the vena cava. Maybe if this is small, yes, the retroperitoneum tamponates itself the bleeding from the vena cava. And about the diaphragmatic injury, I would not be concerned about a future hernia, because yes, the liver does protect against an hernia. But our concern is, for example, we had a case of a bronchobiliary fistula, and the only past history was a previous stabbing wound in the thoraco-abdominal area. And that's the reason I would take a look at diaphragm and repair if I could. Well, besides that, I don't have any further comments. That's a good case. Thank you. Good day.
Thank you, Dr. Calderon. Dr. Calais, Sao Paulo, your final comment, sir.
It's a very good case, and something is very important to think about is that the case that or treat conservatively. There is no trauma surgery become important for treat these patients. You have to think about it. There's many conservative management and diminish the case for the surgical treatments for this patient. So it's very important to know this when I to talk about trauma surgery. I think it's very interesting case. Congratulations, Gustavo, for the presentations. And one thing that you don't have to talk, but it's very important to talk sometimes, is if you go in this situation, you see the patient have an injury in the vena cava. Sometimes it's important sometimes may be useful the use of Reboa into the vena to tamponate the injuries where we go to approach these injuries to avoid bleeding during the surgery. Can ask for Dr. Ordóñez in Colombia. This case comes from Colombia. Probably they go to get a Reboa, and it's very interesting to think about this. So congratulations for the case. Thank you for the presentation, Gustavo.
Thank you, Dr. Calais. Dr. Chiadetis, your comments, please.
I want to congratulate you on this case. I still feel a little nervous about sleeping on a injury in the vena cava, so I guess I'm gonna need to learn how to not to operate on everyone with a vena cava injury. I think I have time to do that. So thank you for the presentation, Gustavo.
Thank you, Dr. Chiadetis. Atlanta, Dr. Frisbee, your final comment, sir?
Well, you don't need to see my ugly face, but here's the comment I have. You know, I still would have gotten, I believe I would have gotten the vena cava if it wasn't, if for no other reason than you need, you know exactly where the injury is. The other thing is it was very well managed, and there's a small study out of Emory about 10 years ago where Feliciano and his crew were, doing this exact same thing. If you get a stab wound across the diaphragm, either through the right liver or above into it, they elected not to repair the diaphragm in that case. Since the mass of the right lobe of the liver would be enough to prevent any further eventration of the diaphragm, but I haven't seen it reproduced lately. I think the case was very well managed, very nicely done. Congratulations.
Thank you, Dr. Frisbee. Dr. Moscoso, your final comment, sir?
Yeah, it's a very interesting case, and I think it's a good example of non-operative management. Congratulations for the job. Very good case.
Thank you, sir. Portland, Dr. Kasim, your final comments, please.
Well, two comments. Number one, you cannot make a patient any better when he's already well. Number one. Number two, to my colleague from Panama, you need to be scared of the inferior vena cava, because I have dealt with a few cases of the vena cava injury. Some of them are gunshot wound, but still, it is fraught with danger. You can exsanguinate very quickly, and then you will have an operative death. And that's happened to me as well when I was in Bosnia. So, what are my thoughts on this? I think anytime I see an inferior vena cava injury, I take it very serious. And in this particular case, I still would have done an IVC angiogram, venocavogram, to see what I'm fought with for the future. And I think Dr. Calderon's thought of deploying non-operative endovascular treatment is a very good one as well. And I shall keep that in mind for the future. If you have to operate on these patients, very quickly you can lose a few units of blood in a matter of seconds, not minutes. And anytime you open the retroperitoneal hematoma, you should say a prayer, because you might have a patient who could succumb on the table. Be careful. I think Dr. Fraga, being a very good surgeon, he exercised his judgment and got the patient through successfully. Congratulations to the team. Thank you.
Thank you, Dr. Kasim. Before we turn it over to Dr. Marttos, do we have any other final comments on the case? Okay, Dr. Marttos.
Yes, hello everybody. I was watching remotely here. Again, Dr. Fraga did a great case. This meeting has 10 years, and since the first meeting, Dr. Fraga and Dr. Tele were always connecting throughout these years, so they always have great case from their academic institutions. I'd like to say congratulations for both for always being here. Glad to see colleagues from Peru. Glad to see Marta here. The Pan-American Society, next year, we have a lot of plans for these meetings. Next week, we're going to have the board meeting, and then the other one, following week, we're going to have the General Assembly. I'm going to announce as new president the new activities that you're going to have, and the idea that you're going to meet each other more often and discuss case and learn with each other, and have a lot of new things on the website where the members can just go there and find the recorders and lectures, can find reference, can be a place, the Pan-American Society can be a place where we all in Latin America can meet, can see our friends, and can enjoy time together before the Congress, right? And I hope next year the Congress is going to happen in person. So thank you very much. Please, I need to create the agenda for the next few meetings. Next one is at 8 a.m. And the other one is 12. I need some more case. Please let me know who has good case to be presented, and contact Valeria tomorrow, day after tomorrow. Thank you very much. See you all next week. Take care.